Welcome to this clinical explainer on diagnosing and managing primary anxiety disorders. I'm so glad you're here. Look, if you are a focused learner looking to master the exact, rigorous pathways of clinical diagnosis and treatment without any of the extra fluff, you are absolutely in the right place. Today, we're taking a deep dive into the precise criteria and management protocols that differentiate these complex presentations. We have a ton of highly actionable clinical material to get through, so let's just get straight to work. Okay, let's dive into this. We're going to methodically break down 5 critical areas today. First up, the rule-out hook. 2, generalized anxiety disorder. 3, specific and social phobias. 4, diagnosing agoraphobia. And finally, number 5, a complete panic disorder breakdown. Let's start right off with the rule-outs.
I want you to picture this. You've got a patient sitting right in front of you, and they are presenting with severe, overwhelming anxiety. I mean, their skin is pale, they're sweating, they're practically close to tears. It is so incredibly tempting to just jump straight to an anxiety diagnosis, right? But you've got to ask yourself, is it really an anxiety disorder? A primary diagnosis can only be made after definitively excluding physiological effects. You absolutely must confirm that what you're seeing isn't just driven by a substance, a newly prescribed medication, or an underlying medical condition.
To do that, we need to run through a vital clinical comparison. On the psychiatric side, you've got to rule out depression. And here's a key clinical pearl for you. If the depressive symptoms showed up first, if they're more severe, or if the anxiety is distinctly worse at night, you're very likely looking at a primary depressive disorder. We also need to rule out schizophrenia, which is an unusual but totally possible cause of fear. Then we pivot to the medical rule-outs, which, to be honest, are vast. You've got to clear cardiac issues, think ischemic heart disease, arrhythmias, or electrolyte disturbances. You need to rule out respiratory events, anything from a pulmonary embolism to an asthma exacerbation. And of course, always keep thyrotoxicosis, hypoglycemia, and anemia on your radar. Only when those pathways are cleared can we actually move forward.
Let's move to Section 1 and see how this builds. Generalized anxiety disorder, or GAD, covering diagnosis and treatment.
Now, GAD isn't just your run-of-the-mill everyday stress. It's this persistent, catastrophic worry about completely ordinary things. The anxiety basically permeates everything, to the point where a catastrophe seems entirely possible or imminent, and the patient simply cannot put those concerns aside. And the defining metric for a formal diagnosis here, it's the number 6. We require exactly 6 months of this excessive anxiety. It has to happen on more days than not across that entire half-year period. On top of that, the patient has to find it incredibly difficult to control these worries. So if they've been intensely worried for, say, only 3 months, well, it just doesn't meet the strict DSM threshold for GAD.
Alongside that 6-month timeline, the diagnosis requires exactly 3 out of 6 specific symptoms. Let's unpack the nuances here because they matter. Sleep disturbance in GAD is highly specific. It's usually initial trouble falling asleep or having unpleasant dreams, which is pretty different from the late insomnia we often see in major depressive disorder. Muscle tension is another huge one. It frequently shows up physically as restlessness, trembling, or a persistent tension headache. You also want to look out for fatigue, poor concentration where the mind just goes completely blank, and a heightened sense of irritability. All right, so once you've diagnosed it, the management protocol is highly structured. Step 1 is non-pharmacological. We start with self-help materials based on cognitive behavioral therapy principles, group psychoeducation, relaxation techniques, and biofeedback. Moving on to step 2, this covers short-term medications, typically utilizing benzodiazepines or buspirone. And note carefully here, beta blockers are used for performance anxiety. They are not a treatment for GAD. Finally, step 3 is long-term management. For this, we rely on SSRIs, SNRIs, or pregabalin. Antipsychotics and anticonvulsants, those are strictly reserved for treatment-resistant patients.
Section 2, specific and social phobias. It's time to differentiate the fear. And this brilliantly illustrates how phobias differ from GAD. Unlike GAD, phobic anxiety happens almost exclusively in specific circumstances. The patient's entire life gets altered by active avoidance and this really intense anticipatory anxiety. The dividing line between the two main phobias is fascinating. So both require a 6-month duration. But specific phobia is an immediate, totally out of proportion fear directed at a particular object or situation. We're talking animals, natural environments, blood, injections, or triggers like airplanes and enclosed spaces. Social phobia or social anxiety disorder is an entirely different beast.
The fear isn't of the situation itself, but rather a marked fear of possible scrutiny, embarrassment, or acting in a way that will be negatively evaluated by others during social interactions.
When treating specific phobias, the undisputed main approach is the exposure form of behavioral therapy. But clinically, we actually have a really cool pharmacological tool up our sleeves, D-cycloserine. This is a partial NMDA receptor agonist, and its job isn't to cure the anxiety on its own. Instead, it uniquely augments and enhances the efficacy of the exposure treatment. It's basically a brilliant way to actively rewire the brain during therapy. Now, in some really severe cases, a few isolated doses of benzodiazepines might be needed, but exposure therapy absolutely remains the core mechanism of action. When we put the management of the two side by side, there's a stark contrast. While specific phobia relies heavily on exposure therapy and potentially D-cycloserine, social phobia requires a totally different approach. For social phobia, cognitive behavioral therapy is the absolute definitive treatment of choice. If you're escalating to pharmacological management, you don't just rely on exposure. Instead, we prescribe SSRIs or SNRIs, and these have to be given for a robust duration of at least 6 months to actually ensure efficacy. Section 3. Diagnosing agoraphobia. The fear of no escape. Agoraphobia is often misunderstood, but it's a very distinct disorder. It's fundamentally driven by a terrifying anxious cognition, the belief that fainting, losing control, or developing panic-like symptoms will happen when away from home, and that no one will be there to save them. Because of that, these patients strongly prefer to have a friend or relative with them at all times. To make a strict, formal diagnosis here, the patient must experience intense fear or anxiety in at least 2 out of 5 highly specific situational categories. Just one category isn't enough. The diagnostic threshold explicitly demands 2. So, the crucial point is knowing exactly what those 5 situations are. First, using public transportation. Next, being in open spaces. Or, conversely, being in enclosed places. Then, standing in line or being in a crowd. And finally, being outside of the home alone. The unifying clinical theme across all of these settings is the patient's internal thought process. They actively avoid these environments because they genuinely believe escape might be incredibly difficult or help might just be unavailable if incapacitating or embarrassing symptoms suddenly strike.
Managing agoraphobia follows a really precise stepwise progression. Step 1 integrates both cognitive behavioral therapy and exposure therapy. Step 2 actually mirrors the pharmacological treatments we use for panic, utilizing maintenance drugs like SSRIs, SNRIs, or tricyclic antidepressants. Finally, Step 3 involves targeted pharmacological intervention. Specifically, alprazolam is utilized for cases of agoraphobia that are directly complicated by frequent panic attacks.
Section 4. Panic disorder breakdown. Let's look at the anatomy of an attack. A panic attack is an extraordinary autonomic event. It's a sudden attack of anxiety where physical symptoms absolutely dominate the picture. The anatomy of an attack is rapid. The anxiety builds up to a severe peak within 10 short minutes, accompanied by hyperventilation and this terrifying fear of a catastrophic medical consequence, like having a heart attack. Thankfully, these usually resolve in under an hour. Now, to clinically define a true panic attack, rather than just a really bad episode of severe anxiety, a patient has to present with an exact minimum number of symptoms. Remember the number 6 for GAD? Well, here that number is 4. They must experience at least 4 out of 13 specific clinical symptoms during the episode. Seriously, imagine diagnosing a patient experiencing this overwhelming autonomic surge in real time. You need to rapidly identify 4 of these 13 symptoms. Think cardiac first. Palpitations, chest pain, or discomfort. Then respiratory, a sensation of shortness of breath or feelings of choking. Notice the physical autonomic reactions: nausea or abdominal distress, sweating, trembling or shaking, chills or intense heat sensations. Neurologically, they might feel dizzy, unsteady, lightheaded, faint, or experience paresthesias. And finally, you have the severe cognitive and emotional symptoms: derealization, which is a feeling of unreality; depersonalization, feeling detached from oneself; the fear of losing control or going crazy; and the profound, visceral fear of dying. But diagnosing a panic attack is not the same as diagnosing panic disorder itself. To diagnose the disorder, we need a different set of numbers. First, you need at least 2 recurrent, unexpected attacks, meaning they aren't just in response to a known phobia. But critically, we look for the number 4 again. At least one of those attacks must be followed by 4 weeks or more of persistent fear of having another attack, constantly worrying about its implications, or making a significant maladaptive change in behavior, like completely avoiding public transport or exercise.
Now, what's really interesting about this is how we actively combat this intense disorder. Treatment is strictly split between medication and psychotherapy. On the medication side, the strategy usually spans 8 to 12 months. We can use high-dose benzodiazepines, especially alprazolam, but caution here, this carries a massive 30% risk of addiction and withdrawal symptoms. The far safer first-line approach is using small doses of FDA-approved SSRIs, specifically fluoxetine, paroxetine, and sertraline, which you increase gradually. On the psychotherapy side, the major focus of CBT is just brilliant. It provides direct instruction to dismantle the patient's false beliefs and misinterpretations of mild bodily sensations as indicators of impending doom or death.
Which leaves us with a critical challenge for your clinical practice. You now possess the rigorous diagnostic parameters and management pathways for these primary anxiety disorders. So ask yourself, the next time a patient sits in your office hyperventilating and misinterpreting a simple elevated heartbeat as catastrophic impending doom, how will you actively rewire that cognition, rule out the medical mimics, and deploy the precise pharmacological and behavioral tools we've explored today? The path to effective treatment relies completely on your mastery of these exact details. Keep analyzing, keep learning, and I will see you in the next explainer.